Hello and welcome to Module 1 of 5 total for Clinical Infectious Diseases Assessment and Management, designed for residents, students, or clinicians who want to prepare for clerkship or residency rotations in infectious disease. My name is Jackson Stewart. I'm an infectious diseases clinical pharmacy specialist, and for those of you who want to skip this intro, I've included a timestamp in the description, but for first-time viewers, I want to explain the purpose of this series. Many residents and students find infectious diseases one of the most difficult topics in medicine. It's difficult to integrate all the memorized knowledge in school for microbiology, pharmacology, and disease pathology to a real case, and in real life there are no multiple choice questions. This is not infectious diseases made easy, since it's not easy. Instead, we will go over the fundamental knowledge you should commit to memory in the first 3 modules, and then we'll create a systematic approach that you can apply to every infectious diseases case you encounter so that you can think like an infectious diseases clinician and apply all of that knowledge. In our last module, we'll go over some high-yield cases that, if you're able to follow along, will arm you to handle most cases of infectious diseases you encounter on the wards. In this module, we're going to focus on developing a strong organizational schema that you can use to memorize bacterial organisms relevant in infectious diseases. We will be applying this constantly in later modules. Next, we will cover the organisms which are part of our head-to-toe microbiota, highlighting specific need-to-know bacteria, and then discussing some high-yield concepts in microbiologic testing for infectious diseases. You will hear me say this several times in these modules, but its importance cannot be overstated. An important difference between how infectious diseases trained clinicians and other providers think is that in infectious disease, we do not see antibiotics as being paired for a disease, but instead we always think about them as a treatment for this specific pathogen. In this way, we are always asking ourselves, what pathogens are at play in my specific patient? When choosing an antibiotic, this is always the most important question. If you learn to think this way early, you will realize the importance of anticipating and knowing the microbiology when assessing an infectious disease. Of course, we cannot cover all microbiology relevant in infectious diseases. There's a reason why there's an internal medicine subspecialty service dedicated to infectious disease. Many cases are simply too complicated or involve pathogens which are too uncommon to teach to all providers. However, we will cover the bacteria that I think are relevant in 90+% of practice involving infectious diseases. So learn who your local ID expertise is and become comfortable asking them questions for uncommon infections or organisms. The problem with microbiology for most learners is that there are simply too many bacteria to memorize. Even if you could memorize them, organizing them in order to be able to recall them when you need to is not a skill that is taught well in undergrad. In our module today, we are going to create a targeted memorization strategy which involves creation of an organizational schema so that we can routinely access a complete list of relevant bacterial pathogens. There are more bacteria than this, and we should learn to become comfortable when asking for help when we encounter these uncommon pathogens. Whenever you start thinking of infectious organisms, we should remember our overall schema. Pathogens actually come in several varieties, namely bacteria, viruses, fungi, and parasites. It is important that we don't forget that non-bacterial organisms can be the cause of an infection, and these of course would not warrant antibiotic agents. We will focus on bacteria today. Within bacteria, I want you to memorize and categorize pathogens into just 4 easy to manage groups: gram-positive, gram-negative, anaerobic, and atypical organisms. Mycobacteria are technically bacteria, but are beyond the scope of this module. So 4 groups is easy enough to manage. Let's break down each, which will be less cumbersome than you think. The first group is gram-positive organisms. Although there are many members, there are only 3 I want you to memorize, and that formed actually the grand majority of clinically relevant infections. And these 3 are all gram-positive cocci: Staphylococcus, Streptococcus, and Enterococcus. Done. Easy enough. However, we can break these 3 organisms down a bit further to get to some important clinical distinctions. First, I want you to break Staphylococcus into 3 organisms, all of which on a gram stain would appear as gram-positive cocci in clusters. And that is methicillin-sensitive Staph aureus, methicillin-resistant Staph aureus, as a distinct organism, and coagulase negative Staphylococcus, which really refers to any Staphylococcus without aureus at the end. Functionally, these exhibit different antimicrobial resistances, so it's important to treat them as distinct organisms. I want you to break Streptococcus into 3 organisms as well. Beta hemolytic Streptococcus, which are the group streps like group A strep or strep pyogenes, or group B or CG strep. Another group we'll call GI strep, since they are found in the mouth and GI tract, including Viridans group Streptococcus and Streptococcus aeruginosus. And the last organism we'll call respiratory Streptococcus or Streptococcus pneumoniae, since it causes upper and lower airway infection. The last organism is Enterococcus. We'll break it down into just 2 organisms, Enterococcus faecalis and Enterococcus faecium. Faecalis is much more common and is typically drug sensitive, so particularly beta-lactams we'll discuss in Module 2. But remember that Enterococcus faecium is often drug resistant, so we need to think about faecium as a distinct organism and clarify when we're actually discussing faecalis or faecium. Notice there are several gram-positive rods that you actually might recognize, although they are either uncommon pathogens or cause unique clinical syndromes like listeria that infectious diseases should be involved in to manage. Look these up or contact your local expertise for advice with these organisms. In the second of our 4 groups is gram-negative bacteria. This is the largest group we'll have to memorize, but we can even break this group into just 4 subgroups. The first we'll call Enterobacterialis, which refers to their bacterial family, although is mostly a term we'll use for convenience purposes. The 3 organisms we should memorize in this group which exhibit similar drug susceptibility are E. coli, Klebsiella species, and Proteus, in particular Mirabilis. These organisms are generally sensitive to the same antibiotics but can also produce drug resistance enzymes in a similar fashion, so we'll keep them together cognitively. The second group we'll call miscellaneous, since these organisms are fairly common, have similar antibiotic sensitivities, but really have nothing else in common. We'll memorize 4 here: Haemophilus species, Neisseria, Moraxella, and Salmonella. The third group has been called the spice group, or spice ham with an expanded mnemonic, since these organisms have been known to have the ability to express an inducible beta-lactamase enzyme. They do not always do this, but they do have that ability, and similar antibiotic sensitivity, so we'll group them together functionally. The 3 I want you to commit to memory from this group are Serratia, Citrobacter species, and Enterobacter species. Don't get Enterobacter confused with Enterococcus, which is the gram-positive coccus we need to memorize. The last group of gram-negatives we need to memorize are a group of bacteria which can be identified on initial preliminary microbiologic testing to be non-lactose fermenting gram-negative bacilli, which is not useful knowledge clinically other than that we can predict that this refers to either Pseudomonas species or Stenotrophomonas. There are others, but these are the most common. These 2 organisms have special antibiotic resistance and must be memorized individually. With that, we are done memorizing the majority of organisms that we need to for bacterial infectious diseases. Go over these last 2 sections as many times as you need to memorize this schema. A small group to memorize is the anaerobic bacteria. Anaerobes can be gram-positive or gram-negative, but because they have unique antibiotic susceptibilities, they should be memorized into a separate anaerobe group. Functionally, we'll just split this group into 2 small subgroups, the oral anaerobes that live in our mouth, and the colonic anaerobes or enteric anaerobes which live in our gut. These organisms can actually be found sometimes in both locations, but it is useful to memorize that in general, they are treatable by different antibiotics. Oral anaerobes like Prevotella or Peptostreptococcus can often be killed by penicillins, whereas our colonic anaerobes usually require stronger anti-anaerobe agents like metronidazole. I would memorize the names of a few colonic anaerobes so that you can recognize them if they are found in relevant infections, namely Bacteroides fragilis, Clostridium species, and Fusobacterium. The last group to discuss is the atypical bacteria group. Atypical bacteria are atypical for a reason. They are either so small that they cannot be seen on typical microscopy, or they lack a cell wall, which makes them impossible to stain using our typical gram stain methods with crystal violet. Although there are many weird and wonderful atypical organisms, I would memorize one group in particular, the respiratory or urinary atypicals, since they actually cause relevant respiratory disease and are commonly found in the GU tract. The only three to memorize are Mycoplasma species, Chlamydia, and Legionella species. Other atypicals like spirochetes, rickettsia, and others typically warrant an infectious diseases consult service to manage. And that's it. Memorize these bacteria and take your time reviewing this section to recreate this schema, which will help you for the majority of bacterial infectious diseases. Now that we've memorized the bacteria, we can develop a truncated schema, which we will be using throughout the rest of the modules when learning antibiotic spectra of activity. If you always learn spectra of activity in this truncated schema fashion, you will be able to predict for yourself the best antibiotic options for a group of pathogens. Although others may advocate for a trends or oversimplified approach, like beta-lactams cover gram-positives, this oversimplification truly misses key real-life details in spectra of activity and consider of pathogens involved in diseases, such that you can lead to actual error in prescribing or identifying an organism. For example, if you say you get more gram-positive coverage with early cephalosporins, you may forget that no cephalosporins cover any Enterococcus species. Similarly, if you say gram-negatives cause intra-abdominal infections, you might want to treat Pseudomonas or miscellaneous pathogens, which are uncommon GI pathogens. Using the groups we've memorized, I've placed them into this table every time I think about them. The three relevant gram-positive organisms only, so Staph, Strep, and Enterococcus, and you see I split MSSA and MRSA in cons. The four groups of gram-negatives, so Enterobacterialis, miscellaneous, spice, and then the two distinct non-lactose fermenters, Pseudomonas and Stenotrophomonas. The oral and the enteric anaerobes, and then just the respiratory atypicals. Using this schema every time you are considering possible pathogens or learning spectra of activity will help you think like an ID clinician. Memorizing the human microbiota from a head-to-toe approach is critically important because infections at any given site are most commonly caused by organisms that actually live at that site normally. If you can memorize, for example, the organisms that commonly live on the skin, you can predict with much improved accuracy the organisms that will be implicated in an infectious disease involving the skin. This knowledge will serve you in the rest of these modules, but as well on the wards. First, which organisms live as commensals in the brain or the CNS? The answer is none. This protected site should be sterile. Presence of any bacterial organisms in this site indicates a breakdown of normal barriers or introduction iatrogenically of organisms, and this should be taken seriously. A little lower down in our upper airway and sinuses, we do find common organisms living as commensals, most importantly our respiratory Streptococcus, Streptococcus pneumoniae, as well as some miscellaneous gram-negatives like Haemophilus, Moraxella, and Neisseria. In our lower airway, organisms should be relatively absent, since we have an intact mucociliary clearance system which expels organisms that fall into our airway or are inhaled. However, if organisms are found here, they are usually ones that drip down from the upper airway. Thus, the most common pathogens that cause pneumonia are actually Streptococcus pneumoniae and our miscellaneous gram-negatives. In our mouth and oropharynx, we find a mix of mostly Streptococcus, like GI strep or Viridans group strep, oral anaerobic organisms like Peptostreptococcus. Beta hemolytic Streptococcus like group A strep can colonize the nasopharynx and tonsils as well. Lower down in our GI tract, our stomach is mostly sterile, save for organisms like Helicobacter pylori, which can survive the stomach acid. Our small intestine and biliary tree, which extends all the way up into the pancreas, gallbladder, and the liver, share the microbiota of predominant Enterobacterialis, so E. coli, Klebsiella, and Proteus, Enterococcus, as well as Streptococcus. In our large colon, we see that since the amount of oxygen has gone down, we can see more colonic or GI anaerobic bacteria, but still see our Enterobacterialis and Enterococcus. Notably, the peritoneum, which is the visceral cavity containing many intra-abdominal organs, should be sterile, but can be infected. Our genitourinary tract, or GU tract, theoretically should be mostly sterile, but is frequently colonized via the GI tract, since proximity from the urethra to the anus. Thus, if we see organisms in the urine, it is commonly our Enterobacterialis. Lastly, our skin is colonized with Staphylococcus aureus, coagulase negative Staphylococcus, and beta hemolytic strep of all varieties. There is also yeast found on the skin, but mostly found in large amounts throughout our mouth and our whole GI tract as well. Take time to memorize and draw for yourself the microbiota of the human body. This will help you immensely in clinical infectious diseases. So let's try an example. A 48-year-old male, obese with spinal cord injury at the level of T5 to 6, paralyzed with loss of sensation below this level. Bedbound other than when attempting to mobilize. Fecal incontinence is present and the patient develops pressure ulcers related to constant bedbound status, particularly one large sacral ulcer, which is now concerning for infection, particularly with red borders, tenderness, and warmth. The wound is difficult to manage given fecal incontinence contaminating the site. So the question that we have to ask, and you should ask yourself, is if this is infected indeed, what organisms would you expect to be possibly causing this problem? I think to myself first, which organisms are commonly on the skin? So of course, Staphylococcus aureus, Streptococcus dominant, but given the specifics in this history, I have to think that there could be fecal contamination of this site, which would make me think of enteric or colonic microbiota like Enterobacterialis, anaerobes, and even maybe Enterococcus. With practice, you should always be rationalizing which pathogens might be at play in any infectious diseases to best think about how to choose an antibiotic. You may have noticed that there are organisms that are not seen in our normal microbiota, but that we know can commonly cause diseases, for example, spice organisms or Pseudomonas. So the question is, where are they even coming from? The answer is that they have to be coming from our environment. We acquire infections from contaminated food and water or through inhalation, not uncommonly, but unfortunately a very common source of infection is the hospital setting. The frequent interaction with multiple healthcare providers, the various instrumentation and procedures that patients undergo, and the frequently visited beds and wards make infections in the hospital not uncommon. The longer your patient remains in the hospital, the higher their risk of infection. Keep this in mind when considering which pathogens might be at play when a patient has been in the hospital for more than 48 hours. Now, we should discuss a few groups of bacteria that are absolutely critical to know and understand for everyday practice. The first is the gram-positive coccus, Staphylococcus aureus. Staph aureus is an extremely dangerous pathogen and is one of the most dangerous pathogens that causes infectious diseases in inpatient and outpatient medicine. Although it can be involved in minor disease like a simple cellulitis, it can be extremely problematic and life-threatening if it gets into the blood. Staph aureus has the ability to cause metastatic infections. That is, it can hematogenously cause infection at distant sites from its source. Most commonly, Staph aureus gets into the blood, can cause endocarditis by sticking and accumulating on the heart valves or endocardium, as well as bone and joint infections, particularly in the spine and disc space, which can create new nidus of infection. Once stuck to these places, Staph aureus can create a biofilm or vegetation, which can break off and embolize to distant sites, also causing problems. For example, it can cause a stroke from a septic emboli and left-sided endocarditis. For this reason, we always need to know where the Staphylococcus came from and where has it gone once we notice that it's in the blood. Other key clinical points to remember are that Staph aureus is never to be considered a contaminant if it is found in the blood, due to danger. If you find a blood culture positive for Staphylococcus aureus, we should always immediately repeat the culture. We'll want to confirm blood culture clearance before creating a definitive treatment plan. We should always ask ourselves as well if the Staph aureus we're finding in the blood or in any site is likely to be methicillin resistant or methicillin sensitive. Historically, MRSA was isolated to hospitals or close quarters living scenarios. It is used to be taught as being unique to things like prison, nursing homes, or certain geographic locations. However, MRSA in the community is much more commonplace in 2021. Some believe that MRSA is more likely to be present if patients have a history of recurrent purulent infections like boils, abscesses, or folliculitis, like you see in this bottom right picture. If someone has no history of MRSA, no history of these types of infections, it's reasonable to treat them for MSSA empirically until proven to be MRSA. However, if the Staph aureus is in the blood, treating as MRSA empirically is justifiable with opportunity to narrow therapy to MSSA only once proven to be sensitive. It is also important to know our antibiotic options for this extremely common pathogen. There are several options that are IV that I've listed, but knowing the oral options for MRSA is extremely helpful. TMP-SMX, doxycycline, clindamycin, and linezolid are all PO options that have decently reliable activity against methicillin-resistant Staph aureus. Some gram-negative bacteria are able to develop drug resistance to beta-lactam antibiotics by creating enzymes known collectively as ESBLs, or extended spectrum beta-lactamases. Where memorizing our bacterial will now come in handy is separating whether or not the bacteria is likely to do this during the treatment course or more likely to do so over recurrent treatment courses, so over months to years. The Enterobacterialis group, like E. coli, Klebsiella, Proteus, can produce an ESBL, but typically does so over months to years of recurrent therapy. There are also some geographic locations like New Delhi in India, which have higher rates of ESBL producing Enterobacterialis than others. If an organism is suspected of being ESBL producing because of the geographic location it was acquired or because of extensive experience to long durations of antibiotics, treatment against ESBL organisms may be justified. ESBL organisms may also be more common if they're picked up in the hospital setting. The spice ham group is a bit different. These organisms may possess a chromosomal inducible cephalosporinase that is activated after exposure to cephalosporins. So quickly within days, the organism can start to express this beta-lactamase, which might contribute to treatment failure during the same treatment course. For this reason, regardless of how long they have been exposed to antibiotics or other epidemiological factors, which are important for those Enterobacterialis, these organisms are often treated as if they are drug resistant until proven otherwise. In this way, we can predict, if we know the identity of the organism and some background history of their infections and locations of acquisition, the likelihood of drug resistance and treat accordingly. And here I'll show you some options that we have for ESBL producing organisms. Typically carbapenems are most trusted if you really believe a patient has a ESBL producing organism, but there are some oral options that we can use perhaps once we have susceptibility testing. The last important group of organisms to know well are the non-lactose fermenting gram-negatives, Pseudomonas and Stenotrophomonas. The reason these are important organisms to be aware of are that they exhibit unique and specific typical drug resistance profiles that leave many drugs that are typically effective against gram-negatives inactive. We need to therefore memorize some antibiotic options against them when they are suspected, i.e. when the gram stain demonstrates non-lactose fermenting gram-negative bacilli. Pseudomonas is also quite interesting in that it can cause very problematic chronic infections in patients with structural lung disease like in cystic fibrosis or bronchiectasis. In these infections, multiple strains of Pseudomonas may be infecting a single patient at the same time, and each of these strains can have different antibiotic susceptibilities. Creating an effective treatment regimen will therefore require close attention to these antimicrobial susceptibility profiles, and in general, these infections should probably be managed in concert with infectious diseases specialist advice. Both Pseudomonas and Stenotrophomonas are not normal parts of the microbiota. Instead, they are common nosocomial pathogens. If a patient is infected with Pseudomonas, it was probably acquired in the hospital setting. Importantly, Pseudomonas has only one oral antibiotic that has possible activity, which is ciprofloxacin, possibly other fluoroquinolones as well. For that reason, cipro-resistant Pseudomonas becomes a problem when designing longer treatment regimens. This is important to remember. Stenotrophomonas has a strange susceptibility profile, but in general is usually TMP-SMX susceptible. TMP-SMX is generally the drug of choice, even for bloodstream infections involving Stenotrophomonas. Lastly, Steno is typically considered a weaker pathogen than Pseudomonas and may in fact be a colonizer of the respiratory tract in hospitalized patients, but not actually a pathogen. So we should be thinking carefully before starting treatment. Now we should talk about some important concepts in microbiologic testing for infectious diseases. We use microbiologic testing to help us determine, if possible, what specific pathogen might be at play in a particular case. However, it's not as simple as simply ordering a test and receiving an identification and susceptibility result. Instead, results are reported in a cascading fashion. What this looks like in real life is first, the gram stain. So this result is typically available from a microspecimen in the first 12 to 24 hours and demonstrates what was visible on gross microscopy. Thus, if the bacteria is seen in this stage, it will be reported, for example, as a gram-positive cocci in clusters. This can give us a good idea if there is a substantial amount of bacteria found in the sample. An incredibly important piece in this gram stain is also the presence of white blood cells, which are frequently reported as polymorphonuclear cells, or PMNs, which really refer to neutrophils, since neutrophils are the only segmented white blood cell. Presence of neutrophils in the gram stain reflect active inflammation going on in the specimen, which is one part of the gestalt when deciding if a specimen reflects a real pathogen versus an irrelevant colonizer or contaminant. Next, approximately 24 to 48 hours later, depending on the organism, sometimes as late as 4 to 5 days for anaerobes or fungi, we should receive an identification of what the name of the bacteria is that is in the specimen. Sometimes, if in small amounts, the organism will not appear in the gram stain, but will appear in the culture. Often, with knowledge of common susceptibility patterns, we can refine our antibiotic selection even at the gram stain stage, because we would know it's a gram-positive cocci in clusters, but certainly at the identity stage if we understand its common susceptibilities. For example, group A Streptococcus or Streptococcus pyogenes is always penicillin sensitive, so I don't need to wait for the susceptibility report, but this is pathogen specific. Finally, approximately 18 to 24 hours after identification, we can obtain susceptibility data for that bacteria. The lab will not test every antibiotic against the organism, but a pre-selected panel of antibiotics. Further, they may not actually release the results of every test, but instead a pre-selected panel of cascading results. So for example, if an E. coli is sensitive to ceftriaxone, they will not report meropenem susceptibility. This is to prevent unnecessarily broad treatment for this organism. Remember that we can make decisions about antibiotic choice before the final susceptibility report if we pay close attention to common susceptibility patterns, which we were going to discuss at length in Module 2. Although it is a privilege to have microbiologic data in medicine, it must be interpreted correctly for it to have clinical use. Not all microbiologic data can be fully trusted, and a large percentage of the data via this route is difficult to interpret and can be confounded. Let me give you some examples of what I mean. First, a sample could be contaminated. So for example, a sputum culture, mouth flora are commonly present in the sample because the sputum has to move through the oropharynx, and this can cause simple contamination as the sputum travels through the mouth. Next, a sample could represent a non-pathogenic colonizer. So for example, an organism that normally lives at the site and is commensal but is not causing disease. A sample could also have been mishandled, and it could be either falsely positive or even falsely negative. And then another example could be that a culture can be sterilized if antibiotics were given to the patient for some time prior to the collection. Because of this, we need to always deliberately interpret our microbiologic specimens with clinical correlation. In addition, each sample can be collected through a variety of means, but some are better or more reliable than others. So here are some examples of this on the right. First, you can always take a skin swab or a wound swab to see what bacteria are living there. But if there's actually a skin infection, the best is to get a swab that involves collection of pus or purulent material rather than simply swabbing dry skin, since we expect Staphylococcus and other commensals to be living there. For the sputum, an expectorated sputum, or a cough sputum, should be considered the most likely to be contaminated by the mouth flora, but even a bronchoalveolar lavage, or BAL, which is taken by a bronchoscope, can be and is commonly contaminated by mouth organisms since the bronchoscope has to travel through the mouth. Ultimately, we should only be ordering cultures when patients are clinically suspected to have a real infection. Otherwise, we are going to be faced with the task of interpreting microspecimens in the absence of infectious syndromes, which often leads to unnecessary prescribing of antibiotics. An important infectious disease skill, therefore, is to be able to differentiate a positive microspecimen as being indicative of a real pathogen, a colonized organism, or simply a contaminant. Let's break this down by some criteria. For a real pathogen, I would expect that clinically that the patient is infected or sick, if this actually represents a true pathogen in this case. So symptoms of infection, constitutional symptoms, as well as a leukocytosis. On the gram stain, as I mentioned before, I would expect there to be signs of inflammation at the site. So I kind of want to see white blood cells, or PMNs, in the gram stain. Organism site congruence refers to whether or not that organism is a typical pathogen at the site that we collected the specimen. So for example, a wound swab having Staphylococcus aureus, or in the possibility that their organism is never to be considered a contaminant at that site. So for example, if there's Staphylococcus aureus in the blood, I would consider that a real pathogen every time since it's never considered a contaminant. The quality of a specimen with a real pathogen might be one that is of better quality. So for example, a lumbar puncture for a CSF versus an external ventricular drain, which could be contaminated by external organisms. And then the last thing I think about when I try to decide if it's a real pathogen or not is how much organism grew in that sample and how fast did it grow in the sample, which would be indicative of the burden of infection. So I would expect, of course, a high amount of organism to grow and it to grow very quickly. Coagulase negative Staphylococcus is a common bloodstream contaminant from intravenous line poking. But if I saw coagulase negative Staphylococcus in 4 out of 4 collected specimens, so in every specimen collected, and it was time to positivity was only 8 hours, I would consider that fast speed of growth and a large quantity of growth, or high-grade bacteremia, increasing the chance that I consider this to be a real pathogen. Remember, not one cell in this table will help me decide if it's a real pathogen or not. It's a gestalt of all of these factors taken together. For a colonized organism, it could be sick or asymptomatic. I would expect a lack of significant white blood cells with a colonized specimen. The key to decide if an organism is likely a colonizer is if it's repeatedly found in the current specimen and historical specimens. So for example, if a patient has Pseudomonas in a sputum sample every 3 weeks and has had that for now 6 months, it's likely the case that that Pseudomonas is now just a part of the local microbiota at that specific site. The quality of a specimen might be good or it could be of worse quality, and there might be less amounts of a colonized organism versus a real pathogen which is proliferating. A contaminant is the easiest to tell. Usually these patients are asymptomatic, although they could be sick for a totally different reason. The gram stain often has no white blood cells, and the organism is often not even seen on the gram stain, only found finally in final culture. The organism is an expected commensal at that site. So for example, swabbing coagulase negative staph on the skin, or not even a pathogen in that system. So for example, if you collected Enterococcus faecalis from a sputum sample, Enterococcus is never a respiratory pathogen, so I would consider it a contaminant. The quality could be worse, and the quantity and speed of growth should be low. I would expect scant amounts and taking longer than usual to grow. Remember, these are all individual components and need to put them all together to make a decision. So let's do some practice cases before we wrap up Module 1. Our first case is a 45-year-old female with cystic fibrosis who was admitted after a car crash. She's critically ill in the ICU, although is improving. About to extubate, the team orders a sputum sample, so an endotracheal tube suction, which grows 3+ Pseudomonas aeruginosa and 3+ Klebsiella pneumoniae. 1+ PMNs in the sample and 1+ epithelial cells are seen in the sample. The blood cultures are negative. So how would I interpret whether or not these are pathogens, colonizers, or contaminants? In my opinion, based on my interpretation, these would be colonizers. The patient's clinically improving. If this patient was still ill or getting worse at this moment and not about to be extubated, I would have to be forced to consider that these could be potential pathogens in this case. But this is unlikely a pneumonia based on the fact that our patient's already improving. The specimen is clearly positive, but only has 1+ PMNs in the gram stain, so not indicative of abundance of inflammation. The patient also has structural lung disease and CF, so is likely colonized, as they are very common to be colonized, with gram-negative, so I would not treat this Pseudomonas or Klebsiella. The second case is a 27-year-old male who's immunocompromised post-bilateral lung transplant, who is having increased cough, fevers, and chills, new CT chest findings, and has a bronchoscope and a BAL specimen that reveals 3+ PMNs and 2+ Enterococcus faecalis. So my interpretation of this case would be that this is a contaminant. Although the patient is sick and a good specimen, so a BAL from a bronch, shows us this organism and actually quite a few inflammatory cells, we already know that Enterococcus is not a respiratory pathogen. It's not known to cause this disease, and so ultimately this organism is a contaminant. We know that this patient actually looks like they have an infection, so we should be going and looking for other types of infections or maybe even treating them for a pneumonia empirically, but I would not target therapy against the Enterococcus, which is likely a contaminant. In our last case, our 76-year-old male with type 2 diabetes, history of bilateral total hip arthroplasty 2 years ago, and hip pain for 6 months. A blood culture, peripheral venous, is positive for Staphylococcus epidermidis, which is a cons, in 1 out of 1 set of cultures taken at a time to positivity of 9 hours. I have to consider that this organism is possibly a real pathogen. This obviously requires confirmation with a subsequent set of blood cultures, and although coagulase negative staph is sometimes seen as a contaminant, in patients who have prosthetic material in situ, so this guy has 2 hip replacements and bilateral prosthetic hips, cons can actually be a real pathogen and create a biofilm on this material. So on this case, with a fast time to positivity, symptoms and clinical features of infection, and the cons in the blood, I need to consider that this could actually be a real pathogen. We've gone over a lot of material quickly in Module 1. I encourage you to review this module as many times as you need to be secure in the fundamentals in bacteriology, as this information is absolutely critical for our future modules and clinical practice. We've created an overview schema of bacterial pathogens and memorized key members to create a truncated bacterial schema. We've memorized the microbiota of the human body from a head-to-toe approach, focused on key bacterial pathogens, and discussed some key problems with interpreting microbiologic testing for infectious diseases. I've included some bonus slides for your interest, as well as some references if you're interested in further reading. So thank you for watching.